Welcome everybody this evening. We're so happy to have everyone. Oh, Rod, hi. We've got someone from Australia joining us tonight. So that's wonderful. Good morning, I should say, to you. Um, so again, my name is Carrie Williams. I am the Director of Services here at ABCD, and we are so happy to host all of you this evening for this wonderful webinar with Jenny Geurts from the Medical College of Wisconsin to explain to us what's in your genes tonight. So Jenny, please take it away.
Thank you so much for the introduction. I'm loving seeing in the chat here where everybody is from. That is wonderful. And I was just telling the group before we opened here that I just came from Seattle from my professional conference. So I see Susan is joining us from the Pink Lemonade Project and serving that Pacific Northwest area, which, oh my gosh, was so beautiful. And it just what looked like a dream, like another planet. And it's so also moist in the air, not humid. We have humid here in Milwaukee, but it was like moist. The moss was just growing everywhere in between all the cracks on the cement. There was just moss everywhere. So thanks for joining us, Susan, from the Pacific Northwest, and everybody across, now I can say the world, because Rod's representing from Australia. And I do see a bit of a Wisconsin contingency so that's great. I myself am calling from my childhood home. I'm actually in my dad's bedroom right now because today is family dinner night, and we're so fortunate. My father lives close to us, and we have family dinner once a week. So happy to be joining you all here. Really happy to be invited by the group, and absolutely flattered to have this large audience to talk about what's in our genes and genetics and how it's tied into cancer. I'm looking forward to hearing from you all today. I have to say, I will be sharing a slide presentation. And also I let the folks know that there's a PDF of that you as attendees can all have access to. Happy to share that with you. And then also, I'm hoping, because I'm a teacher, and I spend a lot of time teaching in our medical school to our medical students and graduate students, but I would really love to be in dialogue with you all, in communion with you all, and discussing what this information means to you. So I hope that our time spent today for the next 45 minutes or so isn't me just lecturing at you. But rather me also learning from all of you. And if you're willing to share your stories, your experiences, your concerns, your curiosities, that really helps me grow as well. So I'm hoping that this can be an experience where we're all sharing. So thank you for your engagement in advance. Oh, love seeing all these locations coming in: Naples, Florida, Richmond, Virginia. All right. Well, I hope everyone's well today. And why don't we get started? I'm going to go ahead and share my screen. So we practiced this last time. So let's make sure it works again. And you should all be seeing a little green slide up there, seeing some smiles and head nods. Okay, good. So as mentioned, my name's Jenny Geurts. I'm at the Medical College of Wisconsin in Milwaukee, and I'm a professor there in our Institute for Health and Humanities. I specifically direct the program for our Master of Science in Genetic Counseling. So I mentioned I'm an educator. Prior to this role in education, which takes 100% of my time up for any of you that are teachers, you have very little time left when you're teaching. It just seems to consume everything, every hour of your day. But prior to this, I was in clinic, and I was seeing patients full-time in clinic, mostly focused on pancreas and endocrine disease, but did see a lot of breast cancer patients and family history, and a lot of variety of cancer cases at our Froedtert Cancer Center in Wauwatosa there. So that's a bit of my backstory, but let's get into why you're here. Let's kind of pick this all apart, go through understanding those risks, and talk about some myths. And as mentioned, I have some slides prepared for you, but if you have questions, and if you're anything like me and will likely forget the questions if you hold on to the question in your head, just get the question out. Throw it in the chat if you want to unmute and just yell at me, I'll stop. But we also have somebody monitoring the chat, so that's wonderful. So, I told them to please do interrupt me. So again, I'm not just talking at you the whole time. So if you think of something, you want me to pause, you want me to go back and reiterate something, or you thought of something else and you've got some questions, you want to share your own experience, just go ahead and use that chat or unmute. Happy to go in the direction that this group wants to go in today. We don't have to follow an order of my slides. But in general, this is what I was hoping we'd be able to cover. A bit about that risk assessment, risk reduction and management. So what do we do about our risk for cancer? What barriers exist? Because it's not just so easy as, oh, here's a genetic test, let's do it. There's barriers. And then, of course, discussion either at the end or throughout, whatever works for you all. So I thought I would start with just kind of the basics of what is genetic counseling. I didn't want to make assumptions, knowing that folks from all over the world now are calling in today. Just wanted to make sure we kind of start at a foundational spot. So our definition is the process of helping people understand and adapt to the medical, psychological, and familial implications of inherited conditions. So that's a lot all wrapped in. I'm going to break that apart for you. So we try to assess risk of disease. In this case, of course, today I'll be talking about cancer, but we work in a variety of different specialties, including, pregnancy, infertility, pediatrics, cardiovascular disease, neurology. I mean, you name it, we're pretty much available to assess that risk. There is a component of what we do that's patient education. So patients usually come to us with questions, wanting information, wanting to learn more about how testing or family history may impact their care. And we're providing guidance around that. We support patient autonomy and decision-making. And so we're there to help guide the patient through that decision-making. And then, of course, providing support and referrals as needed as well. And, our modern healthcare, there's so much happening. When I started in practice 20 years ago now, I never imagined that we'd be where we are today. It seems like every day there's a new, genomics test or new therapy that's being tailored, something called personalized medicine, where we're not just treating everyone with a condition the same way. We're really tailoring it to their makeup, and their genetics is a big part of that. And so just a little bit of history lesson. It's a newer profession when you compare us to like nurses and doctors more traditionally. So our profession started back in the 1970s, or as my son likes to say, the 1900s, which makes it sound so old. And then in 1979, we founded our professional society, and so we're going on 50 years old here now, which is great and exciting. And we have thousands of genetic counselors, not only in the U.S. but nationwide, including Australia, because they have a genetic counseling training program. So our Aussies are representing in a great way here. And so what does that look like if you go see a genetic counselor? Possibly many of you have already seen a genetic counselor, or maybe were referred, but declined that opportunity, or maybe you were never even referred and are wondering what that looks like. So each appointment is a little different because, again, we try to tailor to what the patient needs are. But in general, I'll kind of walk you through what that looks like. So we usually like to start by establishing mutual goals and addressing patient expectations. So that might look something like, tell the patient, I've had a chance to review your chart and get a little bit of the medical history. I'd like to hear from you what you're expecting out of this visit today. And sometimes patients say, well, I'm just here because my doctor told me to come. I don't know. I've got 100 appointments, and just checking the box, right? Other times patients say, well, this is something I've been thinking about for a while, and I was kind of hesitant, but, finally my daughter convinced me to go, and now I'm here, right? So we get a lot of different, and it really helps if we start with that and kind of knowing where patients are coming from and what they're expecting. So we usually start that appointment by just going through that medical history, just verifying what we have in the chart, and hopefully diving into the family history a little bit deeper. In an ideal situation, patients have prepared for that conversation a little bit and maybe started collecting some of that family history ahead of time. Sometimes patients are unprepared for that, and I start asking family history questions and they say, I don't know. I got to call my auntie. Auntie knows everything. I don't know any of these questions. And so I've been in plenty of sessions where I'm like, do you think your auntie's available now? Let's call her. Let's see if she wants to join in on the conversation. Or I'll give them some paperwork and say, okay, well, when you have a chance later, talk with your family members, collect that information, and I can get it on the back end. That's fine if we don't get it in the appointment proper. Or we get it on the front end. Sometimes genetic counselors send their patients paperwork to fill out. There's always paperwork for every appointment. Paperwork. And then we take that information, the medical history, the family history, and that's the risk assessment piece. So really trying to see, is there something inherited going on here? Does it look like this could be something where genetic testing may be an option? Because we don't have genetic testing for everything, and we don't have a perfect genetic test. It's not a crystal ball, it doesn't predict the future. So we really have to understand what that family makeup is looking like and if we have a technology that may help that family. So we go through what are the risks, benefits, and limitations, addressing insurance concerns. Is this going to be covered by my insurance? So we go through what their insurance criteria are and we take care of that piece. Reviewing genetic discrimination laws. There's a federal act in place called GINA, the Genetic Information Non-Discrimination Act. So we go through what does that cover, what does that not cover? And then a little bit of anticipatory guidance. So what are the possible results someone might receive if they're getting a genetic test? It could be positive, could be negative, and of course the inconclusive, right? Which can happen, and where we get more questions than answers. And then what's the turnaround time? Most genetic tests take about 2 weeks. Some are faster, some are slower, and that can impact treatment. So we've got to talk about how long is it going to take to get these results. And then as mentioned earlier, what is the psychological impact of what we're discussing here? And what does this mean for you, but what does it mean for your family as well? Because that is one of the unique things about what we do, other than when you think about other medical decision making, am I going to get a mastectomy? Am I going to get a lumpectomy? That's a very personal choice. Genetics, very personal choice. And there's big impact for the family members as well. So that's a kind of unique consideration. So there's multiple facets of care. This illustration is just kind of acknowledging that. And really our goal is to create a patient-centered experience, really meeting the patient where they're at, trying to answer their questions and support them in a way that they can make an informed decision that's right for them and their family. So I've been talking for about 5 minutes straight here. We're just going to stop and pause, see if there's any questions, comments, concerns, experiences folks want to share. Hi, Rod.
Hi, I've got a question. Just watching this genetics whole boom in genetics in the last 10 years, I've noticed that when, in my case with breast cancer, we started with a couple of BRCA genes and now the panel's expanded. How do you handle that?
Thanks for the question, Rod. Rod, I feel like you're a paid actor in this because that's such a good question. So what Rod's alluding to is back in the 90s and then the 1990s, the genes for breast cancer, BRCA, breast cancer 1 and breast cancer 2 were discovered by Mary Claire King and group over at Berkeley and then at University of Washington. And they were really revolutionary. It was the first time that we had unlocked an answer for why there was this, seemingly plague, if you will, in some families that were very strong, what we call high penetrance, meaning, gosh, almost everyone in the family was getting breast cancer. Then we appreciated they were getting ovarian cancer and there were men getting breast cancer. And so as they were studying these families, they were learning like, oh my gosh, look at all these cancers that are connected. And it seemed like a lot of people in the family were getting cancer. And that's how we study disease. That's how scientists study disease in medicine, is you go to the most extreme examples first. Let's look at the family where virtually every woman got breast cancer at a young age. Wow, how striking. And boom, these genes appeared. But then as we were learning more and going beyond BRCA1 and 2, we started appreciating that there were other genes of what we call lower penetrance, or just different syndromes, that maybe not everyone in the family got breast cancer, but maybe a few, and maybe it was later age at onset, or maybe there were different types of cancers associated. Maybe there was gastric, like stomach cancer associated, not ovarian cancer. And so scientists started unraveling all the other genes that were tied up in this. And so I will tell you, Rod, when we first started offering the panel testing, as we call it, where we're looking at dozens of genes, the first panels that came out were maybe 7 or 8 genes. And I'd spend a lot of time in education with my patients on, well, there's this gene and this gene does that and this gene does that. And here are the conditions associated and the cancers. And we'd really go through in a lot of detail. And then I thought, I think I might be putting my patients in a state of comatose with all this information that was really maybe not necessarily relevant to help them in their decision making. And as we were discovering more genes, and the panels went from 7 genes to 20 genes to 40 genes, and now we're 100 genes. Really, we couldn't and we shouldn't be spending time going through all the possible genes and all the possible outcomes. So I've really distilled down my counseling. It's a lot less educational, and it's really more, how does genetic information impact what you are going to do today, with your cancer care or cancer prevention, in the future, and for your family. And based on what your needs and desires are, let's figure out, one, if genetic testing's right for you. And then if it is, based on your family history and the information you're telling me, which panel seems like the best fit for you. Because honestly, most of my patients, especially the ones going through a cancer diagnosis, say, I know a lot of this is exploratory. I know we're on a genetic frontier and we're still learning about a lot of these genes. But information is power. And if I can do something, even if we don't have all the answers right now, this information may really help me or benefit my family or benefit the next generation of folks, right? So I really appreciate that question, Rob, because the counseling for me has changed. And although now we have 40 years of some really robust data, or 30 to 40 years on some really robust data on hereditary cancer families, for many of these genes we're looking at, we've maybe only been testing for them for 3 or 4 or 5 years. So we do get a lot of the unknowns, and ultimately the patient has to be okay with the uncertainty, or at least accept it, because that's kind of where we're at with genomics. We don't have a perfect test. We don't have answers for everyone. And accepting that uncertainty, which I think is a common theme for someone dealing with cancer, right? I mean, you could parallel this with so many things. So tell me your thoughts, Rod, about what I just said.
Okay, that's good what you're talking about there as the patient, but how about the next generations being freaked out by your cancer and the cancer in your family? In my case, it's prostate cancer and all my brothers, and my mother dying young from breast cancer, and still no answer from genetics, and even going into genomics with Washington State University. Who's the person there? That's Dr. King. Is that right?
Yes, Mary Claire King. Yes.
Yeah, Mary Claire King, amazing person. Gosh. And so here we are. I'm trying to contain it in my case to my generation and not worry the kids. But my daughter gets put into a screening program every 2 years. My son's got no public screening program. He's on his own, but there's a whole, can of worms you're opening here. So I'm interested to hear how you're handling that.
Well, yes, I like that expression, can of worms. So that's an Australian expression as well. It is a can of worms, isn't it?
Tin of worms.
Tin of worms. So yes, and I think that's where that individualization comes in, because there are, especially when we don't have answers and we don't, maybe like you mentioned with your son's case, maybe there isn't anything we can do for him right now, or he doesn't have access to, what may help. And that's where, then you start to question, is information power, or does information become a burden?
Yeah, that's
And,
it.
yeah, and I think that's where the psychology of all this comes in, because some people are able to compartmentalize. It's hard to ignore family history. And when you see the generations that have come before and you see what their outcomes have been, that can feel very daunting. And people can get quite fatalistic, if you will, like, oh, my destiny's already been decided. Look at, 3 generations back. I know what's going to happen to me, so I'm just going to live my life and kind of compartmentalize that and say, I'm going to do me. There's nothing I can do about that. And I'm going to ignore it. And not that if I ignore it, it goes away, but, I've just got to do what's best for my, mental and physical health. And I can't argue with that, because if there's nothing we can do, then why are we offering the test, right? And this comes up a lot with my students when we talk about like testing for Alzheimer's, right? So where does medical utility versus personal utility come into this? Because there's very little that can be done if somebody's trying to find out if they're at risk for Alzheimer's medically, at least right now, and there might be some clinical trials and stuff, but personal utility, is there personal utility? Might I live my life differently if I know I'm going to develop a condition in the short term? And I think everybody's a little different. And I think that, at least for me, because I can only speak to, my frame of reference, but for me, I have so much hope in scientific discovery and the future, that even if I don't have answers right now for my family, that by going through that exploration, participating in research, staying abreast of the latest that's happening, being a member of a group like ABCD, where you're hearing the cutting edge stuff, that even if it doesn't help me, maybe it'll help the next generation. And so we're not seeing the pattern repeating itself in the family history. Maybe we're catching it younger. Maybe the cancer's still happening, but we're catching it younger when it's more treatable. Maybe someday there's a vaccine. Maybe someday and I know this is maybe a little radical, but maybe someday there's like a newborn screening thing, right? Where, and it's like, oh, here's, some dietary things, and thinking like prostate cancer, like, I don't know, pumpkin seeds. Maybe we're eating pumpkin seeds every day. And, we just know based on our genetic makeup and nutrition that these are the things that we should do. I don't know what the next 20 years looks like, because I'll tell you, Rod, if I had bet 20 years ago that we'd be here, I'm not a betting person. I would have lost a bet, because I would never imagined that we would have gone so far as to now be able to look at our genomes to understand what that risk is. So I'm excited for you and your family participating in research, unlocking those answers. But I have to agree, it's not right for everybody. And so that's where people have to make that decision, hopefully in consultation with a genetic counselor, their family, their support people, and say, is this right for me? Because it's not a perfect fit for everyone.
Okay, thank you.
Rod, you may notice I am not capable of giving short answers to questions.
That's why I ask short questions.
I don't know if that's resonating for anybody else, but I see that Stella has raised, Stella, is that you? Or are you
That's
on a
me.
beach? Are you a mermaid, Stella?
I wish.
Where are you calling from? I want to come there and I want to go
Are you
shelling on
kidding
the
me?
beach with you. You're
Okay.
fooling us. You're fooling us with your background,
I'm
aren't you?
absolutely fooling you. Okay, so I believe I am the first, close to the first that would have breast cancer. in my family. I know my grandmother, I know my great grandmother, and I can count back like 4, 5, 6 generations. None of those had breast cancer. But I do have a great aunt which is 92 years old, still living. Yes. And she also had it, but so I would be the first. So I have a daughter, granddaughters, and so they're being tested and making sure. So should they the one go and try to do the genetics, not me?
Yeah, I like that question, Stella. Because first of all, what it highlights is kudos to you for having that much family history information. Not a lot of people can go back that far. And it sounds like you've got some longevity genes in your family with that great aunt at 92. So that is helping you in your battle because longevity is absolutely genetic. And so I think that I'd have to ask a few questions. One is, we look beyond just breast cancer. So what Rod was alluding to earlier, we know genes can be tied to more than just breast cancer. So is there ovarian cancer? Is there prostate cancer? I'd kind of go through that whole thing. What other cancers might there be? And then we also look at the ages at the cancer diagnosis and the cancer type. So for example, like a triple negative breast cancer, the estrogen negative, progesterone negative, HER2 negative, those are a little bit more likely to have a genetic component. So we'd want to flush that out a little bit. And what I typically recommend is if the person who has had breast cancer could come in for the genetic consultation first, that would be ideal because they're typically the ones that know the most information about their own diagnoses and their receptors and all that stuff, right? They're also the one who's most likely to have their insurance cover it. Okay. And then if we find something, because it's a little bit like a needle in a haystack, all right? So if we find something and we have an answer and we say, aha, we tested Stella. We found this genetic marker. Now we can offer testing to that extended family and say, let's test for exactly that marker that we found. Whereas if you went through the process and we tested you and we didn't find anything and the family history wasn't concerning and we said, okay, well, based on what we're seeing here, it doesn't look like this is hereditary and the genetic testing was normal, then we can be very reassuring for your family members. And they still might want to get screened earlier, but that we're not necessarily talking about having prophylactic mastectomies and all that kind of stuff in family members. And I apologize, I was telling the ladies earlier, I've been talking too much, so I'm just going to take a glass of water. Carrie, go ahead.
Okay.
Yeah, just kind of echoing what Rod said. So I did my genetic testing about almost 13 years ago. And so I do have the BRCA2 variant. My father had prostate cancer. He passed before we determined that he had it, but the genetic counselor knows it did come from him because my mother was then tested. So we know it came from my dad, prostate cancer. So I had breast cancer. Is there any benefit to getting retested because there are now so many more? Also, just a note, and I am though in a pancreatic screening. Every 2 years, every other year, I get different tests for pancreatic because of the BRCA incidence, the higher incidence in that. So is there any benefit to me being retested with some of these new genomes they've discovered?
That's a great question, Carrie. I'm glad you brought that up because I think that probably is the case for many people as they were tested years ago. And either, what you're mentioning like 13 years ago when we just had BRCA1 and 2. And at that time as well, there was one lab in the nation that had the patent on the gene. And so nobody else could do it anywhere else. And it was very restrictive. Very restrictive. And so now that we don't have to worry about the patent anymore, and there's many more genes that we can look at, I think the question of retesting is really valuable for people who originally tested negative, who that didn't find anything, who was BRCA1 and 2 negative, and because now there's so much more we can offer. And then I will say the other thing that is super valuable is recognizing that these are rare genes. And by rare, I mean, 1 in 500 people. That's, so if you think that's rare or not. But so the odds of having more than one thing going on, it's pretty low unless, there was a strong family history on your dad's side and your mom's side, because it is possible you could have something come in from both sides. So I would say it's a pretty individualized thing looking at that. But for sure, if you had genetic testing years ago and it was normal, and they just looked at BRCA1 and 2, or just looked at a small handful of genes, that's the biggest benefit, is to go in back and retest. The other thing you mentioned, you used the word variant, and I'm assuming what you mean by that is the technical term that we use now is pathogenic variant, meaning like it's a mutation and it causes disease. Because some people got genetic testing even recently, and they had a variant of uncertain significance. And those are also people that we'd want to come back and continue the conversation, because we don't know when and if. Oh, sorry. My husband just, you need, the keys are in my pocket. Sorry. I've got a kid that's got to get to volleyball practice here. So just distinguishing a few things. The genetic testing from years ago, if it was normal, yes, I would say it's a good time to reconsider testing. If it's more than, like, let's say 5 years old, genetic testing, if it was a variant of uncertain significance or a VUS, that's another one where it's a good idea. But if you had a pathogenic variant and you just, it's just really one side of the family and it kind of all adds up that, yep, okay, this was tracking and everyone who's had cancer tested positive for this gene, then it's probably unlikely. It wouldn't hurt, but it's just probably unlikely, and it's probably not going to be covered by insurance, because they're going to say, well, you already have a gene, right? And the odds of having more than one is pretty low, but it happens. Great question, Carrie.
There were 2 questions in the chat. I think one was basically like diagnosed years ago, wondering if there's more genes today, which I think you kind of answered. They also had no genetic detected at the time.
Yeah.
So wondering if they should do more. And then Melody has a question about the pancreatic cancer screening.
Yeah, I'll address Kim's question first, because it's the lobular and 42 genes. That's pretty comprehensive, but I have to say, there's our knowledge about lobular breast cancer is not as vast as it is about ductal cancer. So we still have a lot to learn about that. The 42 genes, that's pretty good. What I would say, because the two of you have had, you said your younger sister has had lobular cancer. I'm just reading your note here.
Yes, we're
I
both
think
in our 40s.
probably, yeah, thanks, Kim. I think probably a research study is going to be best for you, because much like Rod's family, your family might have a gene that just hasn't been discovered yet, like the lobular cancer gene, right? So I don't have off the top of my head a study that I know of, but I'm gonna put my email in the chat and I'll be sharing it later too. But if you don't mind emailing me, Kim, I can help find something that might be
sure.
appropriate.
Great, because I have 2 more sisters, so.
Yeah, and lobular, it's a little bit harder to detect, and there's just a lot of nuances there. So I'm putting my email in the chat, and then also a link for finding a genetic counselor for those of you who are like, I might want to consider doing this, and you want somebody local in your area. That's a link for, sorry, Rod, it's just national. But if anybody is international, just email me and I can help find somebody in your country, hopefully. Okay, so that was Kim's question. And then the pancreatic cancer screening. So that's a newer thing. I'm assuming Carrie's part of like a larger, typically it's part of like an academic institution or a study where centers, they're called like centers of excellence, or centers that are highly experienced in doing either the endoscopic ultrasound or a pancreas MRI. That's what we do at our center. In combination with some blood work and some consultation. So there is screening for pancreatic cancer. It is reserved, though, for those right now that are the highest of risk. So those who have a mutation and typically also have a family member with pancreatic cancer. That maybe some studies will take you if it's just the mutation and no family history of pancreatic cancer, but typically the gene plus a family history of pancreatic cancer just kind of depends on what the resources are in your area. So Melody, same thing. Feel free to just email me. I don't have, there's not like, there used to be a registry and now it's kind of a little bit all over the place, but if you could email me with your location, and I'll try to find a center near you. Where we're really hoping, because the screening that's available now, the endoscopic ultrasound and the MRI, it's still quite cumbersome. We're really hoping there's going to be some advancements with some of the stuff, if you've heard about like liquid biopsy, this idea where circulating in your blood, it would be a blood test circulating in your blood, there might be some early cancer markers that could be detected. We've got a ways to go with that, and there's a lot happening in clinical trials, but we're really hoping to be able to offer more for families that have that history of pancreatic cancer. So, okay. How am I doing on time? I knew I would go off script, so this is good. I see a few more questions about testing. So let me go into, if it's okay, let me just go into this risk assessment piece, because that might help answer some of the questions that I'm seeing pop up in the chat here. So just quickly, it may not surprise you to know that cancer is actually due to a genetic process, and I just want to distinguish that from hereditary. So cancer is due to changes in the genes. And the example I give, with community members, medical students, whoever it may be, is with skin cancer, because that's a real visual example. So hopefully we start off with normal, baby smooth skin that's all healthy and the DNA is all working as it should. But over time, our cells get damaged, and they are damaged through the sun's UV rays, right? So those UV rays from the sun cause cell damage, and that presents itself in a sunburn and blistering and peeling, right? So if you get enough sunburns over time, you may develop skin cancer. Okay. It's not just you get one sunburn and boom, you've got cancer. It doesn't work that way. So it happens over time. You need multiple mutations in those genes before the cancer develops. And the example I'm giving you is with skin cancer, because we know the link between UV rays and skin cancer. For lots of cancers, we don't necessarily know the environmental link or the what's causing the mutations. It could just be chance as well. So that's for most cancer, sporadic cancer. Start off with healthy DNA, and then those mutations accumulate over time. But what we focus on in genetics is the hereditary and the familial cancer, which is actually the minority of what causes cancer. The majority of what causes cancer is just those sporadic genetic mutations. Could be random, could be something in the environment, could be hormonal. Lots of things we're still discovering. So most people fall into this 70% of they had sporadic cancer. They were the only ones in their family with breast cancer or cancer at all. It happened after menopause, and that was that. Nothing hereditary going on. But for those who have a genetic predisposition, what we see is they didn't start off with normal, healthy DNA. They started off with that first mutation. And again, that first mutation isn't cancer. So if we go back to that skin cancer example, they weren't born with skin cancer, but they were born now with a predisposition, so that after that first sunburn and that second sunburn, they may have gotten skin cancer in their 20s. Instead of in their 60s or 70s, like most people, right? Because they're already a step into that process, and that first mutation was inherited from either parent. Okay, so that's what we're trying to unlock in cancer genetics. And my role is which of these cancers are hereditary, meaning which folks were born with that first mutation from either parent, and we can detect that in the blood. And this is my friend, the emu. So I know a couple of you have seen me talk before, and I bring up the emu every time. I use this exact same slide for medical students. So I'm giving you the medical student level lecture. The emu helps me teach medical students how to remember. There's so many criteria, an insurance criteria and this and that. What is a red flag? Who should be referred to genetics? Who might we think could possibly have hereditary risk? And these are all or statements. So the E in the EMU is earlier than expected age at diagnosis. So typically breast cancer before menopause. That's an example there. Or let's say, for example, prostate cancer in a younger man. M is for multiple. So even if it's not an earlier age at diagnosis, if there's multiple family members with the same type or related types of cancer, that's another indication for referral. And I list a couple that can be genetically linked here. And then the U is uncommon cancers. So any males with breast cancer is an automatic referral to genetics because that's so rare. I mentioned earlier triple negative breast cancer, the less common type of breast cancer, where it's estrogen negative, progesterone negative, HER2 negative. Those are a little bit more likely to have that hereditary component. So we also look at those regardless of age. Prostate cancer is super common in men, but metastatic prostate cancer that spreads, that's aggressive, that's not common. And that has been shown to be more likely to be hereditary. And then any single incidence of ovarian cancer or pancreatic cancer in the family, regardless of age, is also a red flag. And then, of course, if there's a known gene mutation in the family, we see those folks as well. So this is what I'm telling the doctors. This is what I'm telling community members. If any of those apply to your family, it's worth sending, over whether you use my chart message to your doctor, or you talk to them the next time you have a visit, or you just self-refer. That's another thing too. Many centers accept self-referrals. And if it's not required for your insurance, you can just self-refer because you want more information and you're concerned that you meet one of these criteria for further investigation. So that's our email. So that's how we help our med students remember. Do we have some questions coming in, Amanda?
You have a couple in there, yes.
Okay.
Starting with DW, it said no one got tested many years ago, but one without any history of breast cancer. Why not start now and get tested if newly diagnosed?
Yeah, I've had folks, even folks that were diagnosed with breast cancer 20 years ago, right, come and get tested. And at any point in time, I've had folks come that were offered genetic testing 15 years ago, declined it, and then came back 15 years later. So at any point in time is a good time. If it's something that you've been thinking about, something you've been meaning to do, something that's been suggested, but you just aren't sure, what I tell folks is making an appointment to get the information. That's a genetic consult. That doesn't promise you anything. That doesn't mean you have to get tested. It means you're opening your heart and your mind to a possibility. And it means that you're open to learning more so that you can make an informed choice. So yes, DW, I agree. I think anytime is a good time to consider it. And then I see Caroline's next. And so, yes, so Caroline, yeah, you've got a lot going on there, and the myeloma, right? And you should definitely get retested. Come talk to me, Caroline. I actually, yes, message me. I'm happy to help find someone in your area. Multiple myeloma, we're still uncovering the genetics of that for decades. We've always scientists have thought, oh, it's just a sporadic, spontaneous thing, but we're starting to see families like yours where more than one person has multiple myeloma, and then there's other cancers as well. So again, this might be one where, yes, clinical testing could be repeated, but also there might be a research study that would be appropriate. Oh, and then my buddy, Dr. Underwood. Hello. Early age pancreatic. Yeah. Oh my gosh. Okay. So pancreatic cancer screening, typically what we do is we follow this 10 years younger rule. So, if you had an uncle at 50 that had pancreatic cancer diagnosed, we're going to want to start that screening at 40. And the idea with that 10 years younger rule is that cancers typically take a while to develop. So if we can find it in the earliest, most treatable stage, or even in a precancerous state, that's when we want to start. So yes, testing 10 years younger than the earliest pancreas diagnosis in the family. And we would go out and test, first degree relatives, the siblings, the children, second degree relatives, the aunties, the uncles, the nieces, the nephews. And so yes, feel free to reach out if you want more info on that. So great question. And then Linda, okay, oh my gosh, we got lots. Okay, Linda, I see in here, the first person known on both sides of the family, breast cancer was already very advanced at 53. Dense breast, high risk. Yeah, told yours is not genetic, but now kind of wondering. I would say, if your test was done more than like 5 to 10 years ago, probably worth retesting. But your daughters have a high risk of breast cancer because of me. How does that work? So if I go back to my pie here, so far, all I talked about was the hereditary. I didn't talk about this familial. Okay. So what I suspect is going on for you is that there's not one big strong gene in the family, that especially because you were the only one that you know of in your family. And if you've got a pretty decent sized family, it's one thing to say, well, my dad was adopted and my mom was an only child. Well, then if you've got no family history, it might just be because you have a small family, right? But if you're like, oh, came from a big farm family, I got 10 aunts and uncles on that side, 12 on the other side, nobody with cancer, that is reassuring to a point. But because the cancer happened in you, now we have to think about that next generation. And that's where this familial comes in. So what we can do now is we have risk modeling. So this is where genetic testing maybe hasn't necessarily been helpful other than just to rule out those strong hereditary genes. So we've ruled out the hereditary. But what we do know is that we still need to be proactive for family members. So that's where we call this gray piece of the pie here familial. That there still could be possibly some moderate genetic factors that just haven't been discovered yet, or a shared environment or a shared lifestyle that could be contributing to cancer risk. And then you mentioned the dense breast, which many of you are so knowledgeable, you may already know that breast MRI is typically valuable in better visualizing that breast tissue for dense breast compared to a mammogram or in addition to a mammogram. So we have risk calculators now, basically just fancy algorithms, lots and lots of math, where they take the family history, they take the breast density, they're looking at all sorts of factors related to hormones, weight, when you had your first period, if you've had children, all of that. And they're using those risk calculators to give a risk to see if a patient qualifies for a breast MRI, for additional screening, typically in addition to the mammogram, to better visualize the breast and be proactive for early detection. So hopefully I've answered that question there, but that was a really good one. I see more coming in. I don't know if I'm keeping up with all these questions. Okay. Paget's, you're the youngest of 7 and my mom's one of 10. Never tracked down the family history. Love the emoji you use there. That's an underutilized emoji. Feel like you should follow up. Yeah, absolutely. Follow up. Family history changes. I mean, that's the other thing. What my family history looked like 10 years ago is much different than how it looks now. So when you were initially diagnosed or initially, this was discussed, it may be that there wasn't a history of cancer there or it was unknown. And so, yes, I'd recommend following up. Yes. Yes, my slides will be available. Okay. Okay. All right, Carrie, how am I doing here? And Amanda, did I capture?
Looks like you got them.
Yeah. And then DW says, why don't the oncologists take an environmental predisposition to cancer anymore? Are they just too busy? I need clarification on that. I don't know what that means, what you're asking there. We need phase 2. I'm happy to spend more time with y'all anytime you'd like. So yeah, DW, maybe if you want to extrapolate on that and I'll keep going and then I can come back to what the question was. Okay. So, and again, keep me honest with the time here, okay? Because otherwise I'll just keep talking until the sun comes up.
Yeah, I would say you probably, looks like we're like about 7 minutes to 7:30, but we can go about 10 more if you just have some more slides you
Okay.
want to share.
Okay. All right. Okay. So, just want to share the tools that we use in genetics. So that 3-generation pedigree, this is a family tree. That's the circles and squares. That's what we use. And so when you're getting family history information, it's really important to ask where the cancer started. So, well, if grandma died of liver cancer, what I really want to know is, did the cancer start in her liver, or was it that she had breast cancer and it spread to her liver? That's what matters. So that's what we call the pathology. Where did it start? And then that age of onset. Grandma died of liver cancer at 70. Oh, but yeah, she had breast cancer at 45, right? Okay, well, I need to know that. When did it start, right? And of course, when they passed away is relevant, or, if there was additional things that happened, but knowing when it started and where it started, that's the most important information. We already talked a little bit about gene panels and testing strategy, how we like to try to start with a person in the family that's had cancer first to uncover an answer and then go from there. I didn't mention before DNA banking. So if genetic testing is something you thought about, not sure if you want it right now, sometimes people think about DNA banking for the future generations in case they're not there in the future when a newer test becomes available. You can bank your DNA and you can store it indefinitely. So that's kind of cool. So just wanted to provide a little bit, because we didn't really talk too much about this, and is maybe insinuated with some of the conversation, but why do we offer genetic testing? We offer it ideally because if we find something, we want to be able to detect cancer early in family members when it's more treatable. We want to be able to reduce people's risk for cancer, and we want to be able to prevent that cancer altogether. And ultimately, if they do have cancer or they do develop cancer, we want to provide a more precise treatment for that cancer, what I mentioned in the beginning with precision medicine. So I'm just going to share these slides again. You're going to have these, but we kind of talked a little bit about this already. There's plenty of reasons why people don't pursue testing, plenty of reasons why people do pursue testing, and that may change over time. So we want to acknowledge that, and feel free to look at these slides that they'll send you later. So I guess lastly, and then I'll go to these questions that I see coming in. We've talked about some stories. I just have some stories here, and this story is about a woman. And so this arrow is pointing to the circle here. Is this young woman here with her family, whose father passed away from prostate cancer, whose paternal grandmother, father's mother, had breast cancer at a young age, and whose cousin has now been diagnosed with ovarian cancer. And we talked about the emu. So all you are very smart, just as smart as our med students, and no, this meets all of our emus. You only need to meet one emu, one of the letters to matter, but this meets all of them. And so this one would definitely be a good candidate for genetics. And with that testing strategy, what we did in this case actually is we went to this cousin with ovarian cancer who was just diagnosed, and found out that she did in fact have a BRCA mutation that was likely the cause of her ovarian cancer. And these people are passed away now. That's why that line is through them, and it says D, that's for deceased. But it's likely these folks also had the gene. And unless their DNA was banked, we can't really prove that, but that's a good assumption that we can make. And so now for this cousin, we can offer a more precise treatment because we know that the BRCA mutation is driving that ovarian cancer. And for those patients, they have much better success outcomes and much better response to treatment. So that's exciting for her. But also for my original patient who came to me, who doesn't have ovarian cancer, who was just concerned about the family history, now I can test her for that exact genetic marker that I found in her cousin. So again, insurance is going to be likely to cover that because we've kind of shown that this is already in the family. And then also it's going to be a precise kind of yes or no answer, because we're going to say, do you have that genetic marker that your cousin has or do you not? So that will then lead to that person to be able to hopefully prevent that from happening in the future, whether it be for screening or having their ovaries removed preventively or wherever it may be. And that's a discussion, that's individualized. I'm going to skip ahead here, just in interest of time, and just acknowledge there are barriers and there's plenty of reasons why people don't get the care that they need. I just wanted to point out one specifically here around access, because that seems to be one of the main things that my patients experience. So I just want folks to know that no matter what community you come from, this isn't something that only affects women, it affects men and women. It isn't something that only affects certain classes of people. Like, it's not something that only affects a certain race. We know these mutations are more common in folks of Jewish ancestry, specific that German Jewish ancestry, but it can be in every single ancestry base or race. So if somebody's ever told you, oh no, you're Asian, Asians don't get this, that's not true. That's made up. So we got to make sure we dispel some of these myths. We know certain groups are less likely to meet that EMU criteria because they just don't know their family history. Maybe they're immigrant. Maybe their family was displaced from a war-torn country. Maybe those medical records were never available, or they come from a country that doesn't have the high quality care to even know that there was cancer in the family, And I think we do see that certain groups of people are not getting this information at the right time, because we want to use this to prevent cancer. And so what I'm seeing is a lot of community members are coming to see me after, they've been kind of told, well, this is already advanced cancer. There's nothing more we can do. Oh, why don't you see genetics and see maybe there's something there? Or it's like, gosh, if they would have been referred much, much earlier, this could have potentially been a different outcome. So that's what we're really trying to work on. We're trying to listen to our community members. We're trying to learn from our community members, and importantly, take action. So really happy to see NPR recently did a story about how genetic testing is becoming more affordable. So that's a big piece of it. And we're also working on policy with insurance companies, testing access. Most insurance companies cover this if you meet criteria. So I just put United Healthcare here. That's a big one. Here's all their criteria. If you meet any of those criteria, you get the genetic test. Same with CMS, Medicare, Medicaid. It's covered if you meet certain criteria, and the genetic counselor will help you sort through that. You don't have to sort through your insurance policy. The genetic counselor will help you with that. Okay, so my summary slide, I tried to cover as much as possible, but I did want to end with Thanksgiving's coming. For those of you that celebrate, I don't know if Australia has a similar thing, but it's a time where families come together, and it also happens to be national in the United States, National Family Health History Day is Thanksgiving Day. So if you're seeing the family this holiday season, it's a great time to ask. I know it's probably not something that people look forward to talking about, but getting people together, finding out that auntie that knows everything, knows everybody's business, corner that auntie at family Thanksgiving dinner, bring a pen and paper, and start writing down that health history from your family members. So, okay, my resource slide, and again, I can go back to the Q&A, and I just want to be respectful of everyone's time, because I know realize I'm at the hour now. So. And yes, I'm happy to come back for a phase 2. Dr. Underwood, we do not need a referral to get an appointment at MCW. People can self-refer, and so yes, no worries there. You can just call up that line. And I rarely come across an insurance that requires a referral. It's just for a consult, so it's not something that we typically need like prior authorization for. Again, that you don't need to call and ask, is genetic testing covered by my insurance? Because we take care of that. That's our job, is to go through the family history and look at the criteria, and we let you know if there's going to be any out of pocket. But coming to see us is just like an office visit. So that's, just something pretty standard that you typically don't need a referral for.
Jenny, this was really outstanding, and the questions were very, very enlightening as well. I wish there was an opportunity or time for a phase 2, in all honesty, because there's so much really enriching information that you shared. But my other question that I put in the chat, I've got a remarkable graduate student, a doctoral student, that I would love, if you are amenable to it sometime, next year, her spending some time with you. And not just myself, I'm sure others on the line might have similar, students or colleagues that I think could benefit from learning under your tutelage.
Oh, we'd love that. There's such a good value for interprofessional education, even learning alongside my students and what your students doing. And so, yes, I'd absolutely love that. You know how to reach me.
I do.
So
Thank you very
happy
much.
to do that. Yes. And then I just want to get back to MC's or DW rather. DW's question was with the risk factors and how come oncologists aren't saying like, what was your occupation? Where did you live? Like those environmental concerns. Yeah. It's really tricky. It's really, really tricky. It's epidemiology, the study of these factors is really hard to tease apart. You think, it'd be more straightforward if people lived in the same house, did the same job, ate the same food every day all their lives, right? But they don't, and those things change. And right now it is just a big question mark. So I think I don't know why oncologists don't address that more, but what I suspect is that they really just don't know, and they're not going to have good answers for that. So, if if they said, well, what was your occupation? And you said, well, I worked for a dry cleaner for 30 years and I was exposed to, the things in the dry cleaners. I think ultimately they would say, oh gosh, yeah, that probably wasn't good, but we don't know exactly what those sorts of things that you were exposed to and how that might affect your health. And so I think there are certain occupations where there's pretty good connections with cancer causing agents, but we're still uncovering that. And yes, we still recognize there are zip codes where there is disparities around cancer incidence, and we don't know if that has something to do with chemicals being leached from power plants in the water or air that we breathe, or, all these things. And we just need so much more research to take place. So, I'll just do a little side plug. That's why it's so important to have a federal government that is invested in the health of its people, because it takes research to understand and unlock these answers if we are going to be a healthier population and if we're going to help the next generation of people on this earth. So thanks for all the kudos in the chat. I see that, and yeah, happy to come back anytime.
Yeah, we'll definitely have you back. Thank you again, Jenny. This was so informative, like everyone said, and really great. And we will definitely have you back in 2026 to do phase 2 and continue this conversation, because as we know, it continues to evolve and our families continue to evolve. So we're so grateful that you spent this evening with us and answered all of the questions. So again, this will be shared. We will get the recording out and all of the contact information and the slides so you could review them again on your own time. So thank you everyone again for joining us this evening. And again, a big thank you to Jenny. We really appreciate it.
You're very welcome.